she's part of the Kaiser Permanente medical group, and specifically for this talk, what is relevant is she is a member of the Kaiser Permanente Hepatitis Research Network, and will talk to us about hepatitis, some of their efforts with hepatitis C, and then followed by Jeff McKinney, who is a nurse practitioner at the University of California, San Francisco, and has treated more hepatitis C than anyone else I've ever known. So welcome.
Wow, the timer's already going. Thank you all for giving me the opportunity to speak today, and I have no disclosures. So, with the advent of DAA therapy, even though there are special populations who have challenges with access to care or other challenges with treatment, for most of our population, the population that we see in practice, we're lucky that we're able to cure hepatitis C, and we're left with the luxury of thinking about long-term outcomes in this population that have to do with their liver disease or mortality. And for this talk, I'll be focusing really narrowly on those long-term outcomes and risk stratification, specifically for cirrhosis, decompensated cirrhosis, death, hepatocellular cancer. And I will be presenting two studies that were done by the Hepatitis Research Network at Kaiser, and also briefly looking at HCC screening challenges in the post-SVR population, and to see if there's a possible solution to what we see. So for some background, we know that studies have shown that hepatitis C virus cure leads to reduced fibrosis progression, reduced hepatic decompensation, and reduced all-cause mortality. This is true even in the pre-DAA period with interferon use. But we don't know if both for the cirrhosis, decompensated cirrhosis, and mortality, as with HCC, which is reduced in the post-SVR population, we don't know if attaining that SVR reduces the risk of these poor outcomes back to the general or never infected population. So what I'm going to do today is talk about those risks and also see if there is a subset of patients that we can identify who don't have predictors of high risk. So from a population management standpoint, if you are able to identify a subset of people who've been cured of Hep C, who don't need, say, follow-up and specialty care, or may benefit from reduced HCC screening, that could have implications for how resources are utilized. So basically, I'll be presenting two abstracts today that look at this. The first looks at the outcomes of cirrhosis, decompensated cirrhosis, and mortality in the HCV cure population. The second abstract, which was presented by my friend Nazar Mukhtar here, who's in the audience, looks at HCC risks for, who is at risk for development of HCC in the post-SVR population. So the objectives, I'm going to present both abstracts together because they were done on the same population with just different aims, but same methodology. So we wanted to compare the risks of cirrhosis, decompensated cirrhosis, and mortality in patients who had chronic HCV compared with patients who had achieved an SVR, and compared both of them to the general never infected population. And like I said before, we wanted to identify a subset at low risk. Similar methodology for HCC. So for our methods, we included all adult Kaiser Permanente members who were enrolled with us between 2002 and 2019. They had to have one HCV RNA that was positive, at least one, and an HCV antibody. So this was the hypothetical included HCV patient. They underwent entry into the cohort if they had the positive antibody and at least the first positive RNA was when they entered. We collected baseline variables at this point and matched them 3 to 1 with negative controls. Similarly, the attainment of cure was the persistence of the HCV antibody, but the first loss of HCV RNA. And at this point, they entered the HCV cure cohort. We collected baseline variables and matched them similarly to controls 3-to-1 fashion. So you can see that a patient with chronic HCV could contribute person time to the chronic HCV cohort until they were cured, and then they would contribute person time to the HCV cure cohort. For all three groups, patients were followed until they either achieved the outcome of interest, lost membership, or reached study end. These were the variables collected. You'll see this slide included. I'm not going to go into all of them in the interest of time. Our outcomes of interest included, like I said before, cirrhosis, decompensated cirrhosis, all-cause mortality, and the development of HCC. And I'll take a minute to say how we developed our high and low risk cohort. So we said predictors of low risk for any of these outcomes, we identified them a priori based on previously published data, would include the absence of risks for non-alcoholic fatty liver disease, alcohol abuse, and baseline significant liver disease. You'll see how they were defined for the purposes of the study, and we'll see more of this going forward. Statistical analysis, we summarized baseline characteristics and plotted Kaplan-Meier survival curves for cumulative incidence of outcome for each cohort. And the other thing we did was to look at the benefit of HCV cure in relation to controls and chronic HCV. For this, we used a multivariate analysis to control for baseline risk factors while we examined the benefit of cure. Similarly, in the high and low risk group, post SVR, we had Kaplan-Meier curves for each outcome. And these are our results. I'll only point out that the chronic HCV population included 21,184 patients. In the cured population, there were about 11,000 or more patients, and they were matched to a total of 99,000 controls. They were similar in all of their baseline characteristics, as you can see there, except that possibly the HCV cure population had a slightly higher incidence of people who were former tobacco smokers, so they quit. HIV, hepatitis B status was all similar. HCV genotype, which might be interesting, is that the genotype 3 was similar in the patients who failed to achieve a cure and the ones who were cured. Also, baseline liver function was similar between the three groups. You'll see that the albumin and the INR levels were absolutely the same. And finally, the outcomes. So in these three large groups that were studied, as expected, the chronic HCV population had the highest risk for developing cirrhosis, decompensated cirrhosis, or all-cause mortality over the follow-up period. Interestingly, when you look at the HCV cure population, even though their cumulative incidence of these outcomes is much lower than the people who are still infected, it, especially for cirrhosis, doesn't approach that of the control population. I'll draw your attention to the three graphs at the bottom of the screen that show the cumulative incidences. And you'll see that for cirrhosis, the curves never really overlap, though there may be some overlap seen for the decompensated cirrhosis and the all-cause mortality, and we'll talk about that in a minute. This is the HCV cure. Similarly, you see the green line signifies chronic HCV, cumulative incidence of HCC. The blue line is HCV cured population, and the black is the control group. And even though the cumulative incidence of HCC is much reduced with SVR, it never really approaches that of controls. And this is where we look at the multivariate analysis to estimate the benefit of HCV cure in relation to all these outcomes. And you'll see that if a patient with chronic hepatitis C is about 3.4 times as likely to develop cirrhosis in comparison to someone who has never been exposed to hepatitis C. But even with cure, you know, the patient who has achieved a cure still has a 1.7 times higher risk of developing cirrhosis than a control population. You'll see the other predictors of risk there: BMI, alcohol use, markers of significant liver disease and diabetes. All of these were significant. Sorry, going back to decompensated cirrhosis, again, you'll see that, and this excluded patients who had decompensated cirrhosis at baseline. So this is new decompensation, which is the same for the cirrhosis analysis. Chronic HCV patients had 4 times higher risk, or the hazard ratio was 4.1 for the development of decompensated cirrhosis over controls over the period of follow-up. With HCV cure, the risk was similar to, so patients who achieved a hepatitis C cure who were not decompensated did not have an increased risk of developing decompensation over the follow-up period any more than controls. You can see the other predictors of decompensation there. Similarly for HCC, it's interesting to see that chronic HCV patients are about 10 times more likely to develop HCC than controls. With cure, that hazard ratio drops to 5.6. BMI is no longer a predictor of HCC risk, and you'll see that the others stand. So looking at our groups after stratification into high and low risk, I'll remind you that these were done based on the a priori selected variables for NAFLD risk, alcoholic liver disease, and baseline significant liver dysfunction. So if you look at the outcome of cirrhosis, decompensated cirrhosis, or all-cause mortality, when we applied these criteria. So basically we said if a patient did not have a single one of these risks, they were low risk. You will see that the number of low risk patients was quite small, but these patients so identified had a similar risk of developing any of these 3 outcomes as controls. So looking at the graphs again at the bottom of your screen, there's now the HCV cure population has been split into 2, the high risk and the low risk. And the low risk is represented in pink or purple. And there's quite a bit of overlap with the control group in black. So to interpret these data, chronic HCV cure, comparing HCV cure versus chronic HCV, there is a 5-year unadjusted absolute risk reduction in the development of cirrhosis, decompensated cirrhosis, and all-cause mortality. But only the 5-year risk of mortality after HCV cure approaches that of controls. For all other outcomes, we don't see that they return to normal. And in the interest of time, I'll just point out that one of the significant things was the risk of mortality after HCV cure was lower than that of controls. So just the fact that they'd been in contact with the medical system, we postulate is the reason for why they did better. So possibly they benefited from better care and counseling, even for other conditions. So again, I will just point out that the low risk population that we identified in this study did not have non-alcoholic fatty liver disease risks. They didn't have alcohol abuse, and they didn't have baseline liver disease already. So these are the patients that you might possibly think will do well after cure. If they have an albumin less than 3.5, platelets less than 150,000, or bilirubin greater than 1, then those are not the patients in that group. And these are similar data for HCC. In the interest of time, I think I've mentioned this already. I will go on to say that, to summarize that, basically you can look at the population of patients who've achieved HCV cure and identify patients who don't have risks for NAFLD or alcohol and don't already have baseline significant liver disease as a low risk group for any bad outcome long-term from liver disease. But then we're left still with this large proportion of people that do need HCC screening. We haven't been able to exclude the majority of people from that need. So we really wanted to look at how we were doing and also if there's ways to improve. So to set some background, HCC surveillance rates in literature and in practice are really low. I will point you to two meta-analyses that were published in Hepatology 2011 and 2021. In 2011, the pooled estimate was 18%. In 2021, we had improved, but it was 24%. And you can see this is dismal compared to other cancer screening programs. So our objectives, like I said, were to look at our own data to see how well we were doing and to see if a program that we had put in place would have an impact on both the surveillance rates and hard outcomes like early detection of HCC and mortality. And this was a single center retrospective cohort study that I'm going to present to you very briefly. All patients had HCV cirrhosis or F3 fibrosis. The study period was 2013 to 2020. And we assessed adequate surveillance somewhat stringently. I think we said they had to have at least 3 exams done 6 months apart over a 24-month period, and they had to be for the indication of hepatoma screening. And in each patient that was included, we compared surveillance rates pre-inclusion into the program to post-inclusion. I will skip over details of the intervention and what we did, except to say that it involved an MD PharmD team, and the team assumed responsibility for all HCC screening, irrespective of who was following the patient otherwise. Quickly taking you through the results of that study, a total of 602 patients were ever enrolled in this program. And I apologize for the small font there, but the median age of the included patient was about 62. Majority were men, about 3/4, and 3/4 of the population was also Caucasian. But we had a significant proportion of women and other ethnicities that were included. Let's see, 75% of the population had achieved SVR. The other 23% were either ineligible or were in the process of getting treated at the end of study period. Median length of follow-up was around 50 months. And so, you know, it's somewhat humbling when we looked at our data for who was getting adequately screened prior to program inclusion. 18% of our population was getting screened. That rate was 33% if they were followed by a gastroenterologist, and 6% or so if they were followed by their PCPs. Following program inclusion, the rate of adequate surveillance as defined went up to 85.3%. And then when we excluded people who died or had lost insurance, and so we could no longer screen, that proportion went up to 93%. So looking at the outcomes of this intervention, a total of 83 new HCCs, first instance of HCC, was diagnosed over the period of follow-up. Of these, 29 people had HCC actually found on their first imaging study done for screening, and that was usually at program inclusion. I won't go over the other results of the study, but we always felt that those 29 people were somewhat different from the people who were established with the program and had the benefit of prior surveillance. So we looked a little bit more closely at them, and what we found was that if patients were found to have HCC on their very first imaging study, they tended to have one lesion less than half the time, whereas people who we were established in our program tended to have one lesion about 75% of the time, 77% of the time. We've listened to all this talk just now about tumor burden and how important that is, and looking at Milan criteria, who was within Milan and who wasn't. The patients who were established in the surveillance program tended to be within Milan 85% of the time, whereas people who were found on first imaging tended to do so only like 44% of the time. We then looked at mortality rate, and I'll caution you, this is kind of raw mortality data without looking at BCLC stage or cause of death. You'll see that the mortality rate of people who weren't adequately screened was higher overall and at 1 year and 5 years. So in conclusion, I think I can say that programmatic screening for HCC works better when done for a population than point of care type screening. And with a program, we can achieve rates of over 80% in community-based practice. We've also seen that cancers detected during surveillance tend to be smaller and fewer in number and more likely to be within Milan criteria. They may be associated with a lower mortality. We're still looking at the data closely to look at BCLC stage and other liver disease factors to see if we can actually make that assertion. But we are planning larger studies to address that question of a mortality benefit with HCC screening. And with that, I'd like to acknowledge my colleagues on the Hepatitis Research Network at Kaiser, on whose behalf I'm making this presentation today, and also some pharmacists at Roseville who are really, really passionate about HCC screening. So thank you all for listening.
Good morning, everyone. It's really nice to be here today. Thanks to the organizers for inviting me to speak on a topic that I'm very, very passionate about. I've been treating hepatitis C for almost 10 years now. Today, I'll be speaking specifically about our Deliver Care van experience, bringing mobile hepatitis C treatment to services in the San Francisco community. This is my only disclosure. So I want to start first with some background. San Francisco is disproportionately affected by hepatitis C. People living with hepatitis C experience many barriers to hepatitis C care, including lack of regular engagement with healthcare providers. Many don't have primary care providers. Many have unstable housing or are marginally housed. They have active ongoing substance use issues and definitely have many other competing priorities in their lives. Community-based Hep C testing and treatment, therefore, may help to minimize some of these barriers and mitigate disparities in the Hep C treatment care cascade. So just a little bit more background. We've treated a lot of hepatitis C patients since direct-acting antivirals came out about 7 or 8 years ago. However, hepatitis C incidence in the United States continues to rise, and this is partly contributed by injection networks, needle and syringe sharing, as well as homelessness. On the right of this slide, you can see some data from the CDC from 2004 to 2014, showing sort of the rapid rise in opioid injection rates between 18 to 39-year-olds, and a pretty clear direct correlation with acute hepatitis C rates among the same patient population. So we decided to focus our Deliver Care treatment on this patient population who are using drugs. And we chose this patient population because they are at very high risk for hepatitis C transmission. So here's some data about San Francisco specifically. There are estimated to be over 22,000 persons who inject drugs, or PWIDs. 22,000 people are estimated to be hepatitis C antibody positive. From some data published by End Hep C SF in 2017, there were estimated to be 12,000 cases of chronic hepatitis C. And among those with chronic hepatitis C, 68% were believed to be among PWIDs. Also important to note that San Francisco has the highest rate of liver cancer in the US, and this is primarily driven by both hepatitis B and hepatitis C. There we go. I'm sure many of you have already seen this treatment care cascade over the many years, and we know there have been improvements in this treatment care cascade since the advent of DAAs. However, the care cascade, there are still many significant drop-offs along each step of the process, including diagnosis, linkage to care, treatment, and getting cured. With all of these things in mind, the aim of our Deliver Care model was to increase access to hepatitis C testing and treatment for people who use drugs. And our mission is pretty simple: to improve liver health for all by providing mobile health screenings and linkage to care. In order to sort of achieve our goals, we decided to outfit a retired UCSF campus shuttle van. We also joined a collective collaboration of community-based organizations in San Francisco with the purpose to eliminate hepatitis C in San Francisco, and that is End Hep CSF. With the collaboration of End Hep CSF, we were able to identify a variety of locations within the city that are underserved and have hepatitis C service gaps, and chose those locations in which to target and place our van. And then we also obviously trained our team. So one of the first challenges in getting this deliver care up and running was obtaining and then retrofitting a UCSF shuttle van. First, we were able to get some engineers from UCSF to retrofit the van with power and lighting. Then we were able to obtain a phlebotomy station, a clinical exam table, and other furniture and supplies that we use on the van for free from discarded clinics, from discarded furniture that other clinics at UCSF had no need for. We also purchased a FibroScan 430 Mini, in which we were able to do non-invasive fibrosis staging on the van. Unfortunately, we started to do that just prior to the pandemic. We have not been doing FibroScans during the pandemic, but hopefully we'll be able to return to that soon. And then finally, we were able to hire a really good graphic design team to come up with an eye-catching logo for the van and also incorporate UCSF branding. So this is a cartoon overview of the deliver care workflow, and I will go over each one of these steps in subsequent slides. But in summary, we are able to do everything on the van from hepatitis C diagnosis to treatment to cure. And that really is essential to providing these patients with one-stop shopping, comprehensive care for hepatitis C treatment in one place. And we've been at 5 different locations in San Francisco. Currently, we are at 3 different sites. The sites are usually in front of or near a methadone clinic. And we visit each site once a week on the same day, so patients know when and where to find us. The first step in the process is providing patients with a free rapid hepatitis C antibody test using the OraQuick. On site, if the rapid antibody test is positive, we then proceed to gather a blood draw for confirmatory RNA testing. 1 week later, at week 2, patients return and we disclose the hepatitis C RNA results. If the RNA is positive, we offer them treatment on the van. If they're interested in pursuing treatment with us on the van, then our staff will collect treatment intake information, verify their insurance. And if they don't have insurance, then they're also able to get almost every single patient enrolled in Medi-Cal so we can treat them. And then finally, they will also sign a clinical consent form to get the treatment on the van. Like I said, we were doing fibrosis staging with the FibroScan prior to COVID, and we hope to restart that again soon. And the staff and our trained volunteers also provide hepatitis C counseling to participants who want and need more information. The next step is for those patients who have a positive RNA and have chronic hepatitis C, we schedule a telehealth visit with them with a UCSF clinician on the van. And our clinical team is Dr. Price, myself, and one other nurse practitioner, Lisa Catali. Basically, we each have one day of the week where we are the clinician on site for the mobile van. On that day as well, patients will get their pre-treatment blood drawn, including a genotype, liver tests, HIV antigen and antibody, and hepatitis A and B serologies. At the end of the telehealth visit, the clinician will submit the prescription for medication to a specialty pharmacy. And in most cases, that is our UCSF specialty pharmacy. Our goal is to get patients started on treatment 1 week after that initial telehealth visit. Medications are picked up by our delivery team staff from the UCSF pharmacy and bring the medication to the van. The treatment initiation appointment is scheduled with the patient, and the patient engages with a clinician and, the treatment initiation visit. The The patient then meets with the clinician and our hepatitis C PharmD. The patient is given their medications in a Medibox, and it's for 1 week. The hepatitis C pharmacist will then go over how to take the medications. They do a complete drug-drug interaction and medication reconciliation with the patient. They educate them on how to take the medication and also potential side effects. Patients at their treatment initiation appointment receive a medication handout on the specific treatment that they are getting. We use either glecaprevir pibrentasvir, which is Mavorite, or sofosbuvir velpatasvir, which is Epclusa. This is a sample of the medication handout for Mavorite, and it includes essential information that patients can refer to when they're at home about how to take the drug, what the treatment duration is, what possible side effects are, reminders to take the medication with them to the hospital if they get admitted for any reason, when to do blood work, and other important FAQs. During treatment, patients come to the van weekly. We used to have them come to the van every 2 weeks, but we discovered that there was a lot of issues with adherence, and we wanted to sort of support patients better in that regard. So currently our practice is to have patients return to the van on a weekly basis to get their medication refilled in their Medibox. They also have blood draws at identified time points during treatment. The staff will assess adherence and help support them with any adherence issues they might have. And one exciting part of the program, which I'll talk about, I think in the next slide, is they also get gift cards and rewards. Staff will also create an individualized treatment plan for each patient so we can monitor and support them throughout their treatment course. As I said, we have a very, very generous incentive program for patients, and we give them $5 Safeway gift cards, which they can use for anything they can buy anything in Safeway. And if they prefer cash, they can also use the gift card to redeem for cash instead. So patients get a $5 gift card when they do the rapid antibody test. They get a $5 gift card when they can do the confirmatory RNA blood draw. They get another $5 gift card if they come back the following week to get their RNA test results. And they also get a $5 gift card for completing a pre-treatment survey. They get a $5 gift card for the new patient visit when they drop pre-treatment labs. And they also get a gift card every time they pick up meds, for every blood draw they do, and every telehealth visit that they attend. We have a higher gift card value of $20 to really try to motivate them and incentivize them to come back and do their SVR12 labs. And there's a $15 gift card that they get if they attend the SVR12 clinician visit. We are lucky to be able to give out some swag and rewards. These are sort of on an unavailable need. We have snacks, hygiene kits, socks, water, beanies, hoodies, a wide variety of swag that we can give to patients when we have those available. And we could not do this gift card program without funding support from the San Francisco Cancer Initiative and also the SFDPH. The most exciting part of the entire delivered care process, of course, is the cure visit. And so they come back for the cure visit. We share with them their SVR12 results, let them know their hepatitis C has been treated and cured. We also get important patient education, letting them know that their antibody will always remain positive, that they remain at risk for reinfection. We talk to them about reinfection risks to make sure that they're aware of these and promote harm reduction. The majority of patients were able to discharge from the clinic as they don't have advanced fibrosis and don't need ongoing care. For those patients that do have cirrhosis, we refer them to our hepatology clinic at UCSF, or try to make sure that their PCP or other providers aware that they have cirrhosis and have a need for ongoing monitoring and management. And when they do get cured, they really like getting the certificate of cure that really demonstrates that they've been reliable, they've come to clinic, they've taken their medications, and their hepatitis C has been cured. So now I'd like to talk about the outcomes of our screening. We launched the van in early 2019 at 2 sites. And then in August of 2019, we added hepatitis C treatment to the van. Since that time, like I said, we've offered services at 5 different locations in the city of San Francisco. So far, 1,066 patients have been screened for hepatitis C. Of those screened, 408 or 38% had a positive hepatitis C antibody. Of those with a positive hepatitis C antibody, 154 or 38% became what were noted to be RNA positive. And of those who were RNA positive, 87 or 56% opted for hepatitis C treatment with delivered care. And of those who opted for treatment, so far we've had 76 patients start treatment with delivered care. You may notice that there was a significant drop-off between those who were RNA positive and opted for care on the van. And this is really primarily due to patients being lost to follow-up, either not coming in for their RNA results or getting their RNA results but not returning for treatment. And we think this is really compounded by the epidemic. With regard to demographics, this is only specifically for the 76 patients who started treatment. The median age was 54. 67% of patients who started treatment were male. 28% identified as Black or African American. 11% identified as Hispanic or Latino. 9 were mixed or other, and 46% identified as white. And this data really sort of reinforces and demonstrates that we are indeed reaching our targeted patient population. As the 76 patients who started treatment, 100% report a history of drug use. 91% reported a history of injection drug use. 92% reported a history of any drug use. Current drug use is defined as any drug use in the last 12 months. So 80% of those patients reported drug use in the last 12 months. 50% reported injection drug use in the last 12 months, and 72% reported non-injection drug use in the last 12 months. And this is really, I think, one of my favorite slides because it talks about what our treatment outcomes have been and prove to us that our model is working. So to date, since 2019, we started treatment for 76 patients. 60 of those have completed treatment, and 46 have achieved SVR12 to date. 9 patients are still waiting to do their SVR12 labs. We had 2 treatment failures. One treatment failure is currently being retreated on the van, and the other patient who failed treatment is being retreated in our hepatitis C clinic at UCSF. 2 patients are post-treatment but have not reached the SVR12 time point, and 2 patients unfortunately fatally overdosed, and that was after their SVR labs were drawn. 10 patients are still on treatment. 6 patients discontinued treatment prior to the end of treatment, 5 of whom discontinued treatment in the first couple of weeks, and we had 1 fatal overdose in the first 4 weeks as well. So some final discussion points. Everyone who opted for treatment on the van is currently or has previously used drugs, which again reinforces that we are reaching our targeted population. For those people who did start treatment, the treatment completion rate was very high at 90%. 5 patients who discontinued treatment did so sort of very early on in their treatment course and were lost to follow-up. SVR4 and SVR12 rates were very high among those patients who completed treatment. The SVR4 rate was 96%, and we know from a lot of data that showing SVR4 correlates very highly with SVR12. So even if those patients get SVR4 and don't return, we feel confident that they will have gone on to achieve SVR12. Unfortunately, overdose deaths are high in San Francisco, and we also have seen that in our patient population. And the really thing that makes it very gratifying, that makes this project very gratifying for me, is that patients tell me every week when I see them, well, I see them like every 4 weeks, but whenever they do a telehealth visit, they tell me, thank you for coming to my community, being on the street, having the van in a location that's convenient for me to get treated and be tested, get the education I need, get the medications and support. And they're really, really gratified with having the van available to them. A few lessons learned for the group. Hepatitis C elimination, which is really our goal, requires thinking beyond a one-size-fits-all approach. Community-based Hep C screening and treatment reduces numerous barriers to care. Meeting people where they are, meeting them on their schedule. It also helps provide patient-centered care and reducing stigma, and it does allow for co-location of services. What's really important is having an interdisciplinary team and community partnerships that can effectively overcome the challenges of linkage to care and retaining patients in Hep C care. So we invite you to consider how you can expand your practices to be more easily accessible and reach these hard to reach patients in your communities. I want to give a big thank you to the entire Deliver team, especially Dr. Price, who is the brainchild and our inspiration for this project, Rachel Canner, who is the project manager and helped do all the data analysis for me, our funders, our community partners, and our volunteers. And here's a pre-pandemic picture of the COVID team with the Deliver Care. And I don't know if this link works, but you can use this link and copy and paste it into your browser. And it's a really, really nice 2.5-minute sort of cartoon explainer of the entire Deliver Care model. Thank you so much.
Thank you both. That was such an inspiring presentation. I have a couple questions from the virtual side of things. One was whether or not we know anything with regards to reinfection. In this, the follow-up questions, whether or not there was any counseling provided to address codependencies as well as the risk of reinfection.
Yeah, so there's always a risk of reinfection in this patient population. And many studies have shown, however, that the reinfection rate is actually fairly low. We've been doing this now for about 2 years, and I have had only one patient who we treated on the van who was reinfected. He got SVR12 labs. We know he was cured. He came back about 6 months later. He actually came back with a different genotype for, again, letting us know that this was indeed a reinfection. And we're currently retreating that individual. Reinfection rates are real, and we have a very high rate of injection and other drug use in the patient population. So I'm very, very thorough in the reinfection risk discussion that I have with them at SVR12 visit to make sure that they are aware of that and promote harm reduction, like I said. And we've had, during the screening test, we've had, I think, 2 individuals who were tested positive for HIV. They were unaware of their HIV diagnosis. And so we did not prioritize their hepatitis C treatment, but referred them to, it's called the HOT team in San Francisco. So we connected them to HIV care to get them started with HIV care first.
And I believe there was also an abstract at ASLD last year that looked at the question of reinfection in a similar population, and the rates were low. I can't recall the number, but it was in the single digits.
Great, thanks so much, Jeff. It's always so inspiring to hear when you guys present these data, because I think what you've really done is you've flipped the model of care delivery and really bring care to the patients, which I think is so important for underserved and vulnerable populations. With the success that you guys have seen with Hep C, I'm wondering, have you guys had any thoughts about utilizing at least the concept of the same model for hepatitis B? I mean, it's a different population, different sort of disease model, but I think it could also apply to Hep B populations.
Yeah, absolutely. I know that Dr. Price has had discussions with the Hep B free group in San Francisco, which is sort of a similar coalition to the End Hep CSF San Francisco. I think it's something that we would love to do in the future. There's a huge need for hepatitis B diagnosis, screening, and treatment in San Francisco. It was definitely fairly expensive to get the van, obtain the van, do all of the other things to get the van up and running. But we could use the same van and repurpose it for hepatitis B in the future. So I hope that's something that we're able to do, for sure.
Another question from the virtual world. Do you retreat the patients as treatment naive if they were reinfected with a different genotype?
Yeah, that's a really important question. And yes, absolutely. If we have documentation that we can, and confirmation that a patient achieved SVR12 with a previous regimen, and we know that they have risk factors for reinfection, those 2 things together really convince us that this was a reinfection and not a treatment failure. And so in that setting, we can retreat the patient even with the same drug. You know, if they were treated with Epclusa the first time, we can treat them with Epclusa again. Or if they were treated with Mavyret the first time, if it's a reinfection, we can treat them with Mavyret again. So yes, we retreat them with the same drug as long as we're convinced that it was a reinfection and not a late relapse.
A quick announcement before lunch. I know we're all excited about lunch. I just want to remind you a couple things. One is please visit all of our exhibitors and fill out your little form.